As the next speaker, I would like to introduce to you Ms. Maree Bauld. She'll be talking to you about in the digital age. We talked a lot about education in the morning, so I think it's a very suitable topic to bring out at this moment. She's an academic who works with the School of Health Sciences, formerly the School of Nursing and Midwifery, Faculty of Health at the University of Tasmania. She came all the way from there to attend our conference, and we are very grateful to her for that. She has held this position for 10 years and is currently the Bachelor of Health Course Coordinator and Acting Coordinator of Professional Experience Placement. This Bachelor of Nursing Course Coordinator, and she has undertaken unit coordination and lecturing across numerous nursing and health-related subjects. She completed her Master's of Education in 2012 and has a graduate certificate in learning and teaching for health professionals. Her research interests include simulation and technology. And over to you, Maree.
Yes, so thank you for that introduction. And I also do have a Master's in Nursing, so I just thought it would be interesting to let you know that I also worked in ICU for about 20 years, and I've met some of the nursing colleagues here in Sri Lanka in my few days that I was here before the conference, and it seems to be a common theme. And I was also privileged enough to go to one of your local private hospitals, Central, and it was really good to see the facilities that you have there. So I've so far enjoyed my time here, and thank you for having me. I've actually been taking copious notes. I had this presentation organised before I came, but since I've been here, I think there's a lot that I've been thinking about, because I really I feel that I've got a better understanding of the context and situation in Sri Lanka since being here. So I'll probably allude to some new information as I go as well. I'm actually presenting on behalf of Dr. Liz Cummings, Dr. Lisa Dalton, and myself, our collaborators with this paper. And it's just invaluable to be able to come to an international conference such as this and share common knowledge and ideas about these topics. And so I'm really interested in question time, and I've been really interested in talking to people throughout the days that we've been here together. A lot of what I'm probably going to say, or some of my slides, are very repetitive, and you've heard similar stories from previous speakers, so I will actually go over those a little bit more quickly. I just think the thing to add here is just a little bit about the origin of the word informatics, and you can see that it comes from the French, meaning computer, German, which is information, so it's a combination of those two. Will contextualise nursing informatics within the healthcare reform landscape in Australia. Currently what's happening in Australia, and hopefully then for those of you that have been to the conference, you can see the differences and similarities between what you're facing here as well. Also, in this talk, I want to try to elaborate why nursing informatic competencies are so important in our context now as well. So, a little bit about Australia. A similar map you saw earlier. The capital is Canberra, which sits just between which sits in the ACT. We're actually the smallest continent, but we're one of the 6th largest countries in the world, so our land mass is quite large, but our population is only just over 23 million. I come from the very small island down the bottom, Tasmania, and geographically Tasmania is about the same size as Sri Lanka, so you have 23 million people in that little spot, and in that place where I live there are only 500,000 people, and the 22.5 other million are on the mainland. Okay, so just to put it into context a little bit for you. And we are actually divided into 6 states and 2 territories, and this actually becomes significant when we really start thinking about informatics and governance, etc., because what actually happens here, we have a national government and we have policy directives and that nationally, but also each state has its own jurisdiction and its own legislation, particularly around privacy and confidentiality. So we all have different privacy acts, etc. So you can see even with a national rollout of something like an eHealth record, which we have jurisdictions to consider, so lots of communication and thinking around how it's going to work for each state. So it's not as easy as put it up and it all just rolls out, and I think that you're facing that here. I understand with your provinces, etc. This could pose similar problems in decision making and governance. I've probably spoke a little bit about the population, but I think it's interesting too to think that we have fairly high life expectancies, and I hear here in Sri Lanka your life expectancy is 79, so probably similar. But the interesting thing for us, and I'll talk about this in the next slide, is the distribution of our population. So this little scatter map here can see that most of people live on the coast, in the coastal regions, and predominantly down the east coast of Australia. We also have a pocket of 1 million or so in Perth over in the west, but the big purple bit in the middle with it, not too many dots, is predominantly desert. So we don't have very many people living there. There are Indigenous communities and the like. So we do have people living right in the middle, but so you can see some of the issues that might be posed with getting healthcare and information and systems in a vast land like that. I did a quick check today, and pretty much from the top of the east to Hobart down the bottom, it's about 4,000 kilometres. And if you look from Sydney, the capital, on the east, across to Perth, the capital, on the west, it's about 4,000 kilometres. And from the top down the bottom in the middle, about 3,000. So that's a lot of distance that we're talking about. Okay, so I talked a little bit about the governance structure, and I don't really think there's too much more that I want to add here. But the federal government, or the Commonwealth government, is responsible for health policy and also for public funding, so funding the public hospitals. And we have a health insurance, like a system set up called Medicare, which covers healthcare, so it is free for all Australians, and we actually contribute to that through our tax system. So we have a Medicare levy, and it depends on how much you earn as to how much you pay, and that's to support the whole population. So we also have private insurance available to us in Australia, and at the moment of people, of hospital beds are in the public, but about 30% are in private, and I understand your ratios are probably even a little bit closer here at the moment, but please correct me if I'm wrong. Just back to the governance structure as well, it's interesting to note that local government and state government get the distribution of funds from the federal government, and they actually then decide how to use it locally, so whether they're going to spend it in their hospitals, in their primary health, or whatever. So they actually get the money from the federal, but that they decide how they're going to divvy it up in the main locally as well. And local governments, such as is responsible for environmental control and preventative health, such as immunisation. So quite a few different departments involved in the rollout of some of our health. A little bit about health expenditure as well, because I thought it might be nice to just paint the picture. You can see the big blue part of the pie chart is hospitals. So predominantly 40% of our healthcare funds are spent on acute care. And I think this will become relevant in a minute when we talk a little bit about why that perhaps needs to change. And you can see the top chart there is a graph just showing that the health expenditure basically has been increasing over the decades, and this trend won't stop unless we change our healthcare delivery and the models of care and the way that we do things into the future. This slide here is just a little bit about our disease, and you can see here that predominantly cardiovascular disease is the biggest chronic disease or disease processes that we're dealing with, followed by oral health, mental disorders, musculoskeletal, and cancers up there as well in the top few. And I understand that's not dissimilar from what's going on here. And so really what this is telling us is that these most of these are chronic diseases, and so the prevalence of chronic diseases is quite high in Australia, and interestingly most of these are actually preventable diseases. And so this is why I think it's important when we start thinking about informatics and the capacity and uses of informatics into the future, and knowing that it's available for all, and there are lots of apps out there that even individuals can access, that understanding chronic disease, understanding that it's about lifestyle, and understanding the systems that can maybe get right out into the community, etc., will definitely help shape the way of the future. And I think nurses need to be at the forefront of understanding this and being proactive in helping driving what's happening with information, so that right from the patient level through. Okay, I'm just going to catch up with my little notes just to make sure I haven't forgotten to say anything that I really intended to. And I think this slide here is a good one to understand also about the Australian government. Predominantly funds healthcare in Australia. So 46% of health funding comes from the government, the Australian federal government, and state government contributes about 26%. And then the health insurance funds only contribute a very small amount to that. So with increasingly more chronic diseases, etc., and increasing health costs, the government cannot sustain that sort of expense into the future. I talked a little bit about Medicare. I just want to add here a little bit about, we also have a pharmaceutical benefit scheme, which is free medications to patients as well. However, this is highly regulated, so it's not every drug in the world is available to anyone anytime. We have a special scheme, and certain drugs get approved by the board, and those ones are available, but there will be medications that our patient would have the full cost for. But that's actually determined by that committee. And the private insurance schemes are out there, so we are encouraged to take on private health insurance. So whilst we can get free health care in any of our public hospitals, we can also elect to go to private hospitals if we choose, if we have private insurance. And there was actually an incentive put in a few years back where we got a 30% rebate off it if we joined before the age of 30. And I think it goes up about 2% every year after that. So if you put it off and don't take it, it actually becomes more expensive as you get older. So that was just a little incentive there. And the reason why people would take up private health insurance is because of waiting times in public hospitals and presumably better service. I think I've really talked to this a little bit, so I'll keep moving on from that. I've also talked about the growth in chronic disease, mental health, palliative care admissions. Also, we are starting to see more community-based nursing as well, because there is a recognition now that primary health and preventative care is actually quite important, and it is a focus of the government to spend more money on primary health, because they can see that the acute care sustainability is not there. We have a growing an ageing population, so aged care and rural and remote health is also something that we're focusing on. And disability is not on this slide, but disability is a huge area, and we've recently got a new scheme that supports disability. We've gone from being organised in institutions to now individuals package for their disability, and they choose their providers. So disability care is very consumer driven in Australia at the moment, and it's increasingly going to become more so as that national scheme rolls out. So as a result of increased community care, etc., we have also, the government has put in what they call Medicare Locals and local hospital networks. So increasingly now we're moving outside of acute care facilities into communities, and these Medicare Locals are made up of teams of professionals, GPs, doctors, nurses, allied health, social workers, etc. So now we have smaller organisations with collaboration from multidisciplinary teams all working together in areas, in regional areas or outside of major hospitals. So again, I'm just trying to paint the picture of the types of spaces that health professionals are working, so you can see the application of how information technology and technology can be supporting what we do. So the use of the electronic record, the medical records, the dissemination of information between all of these places is paramount. And I have just got that final dot there about the personally controlled electronic health record, and that in 2012 it was a national get all Australians to sign up for this, which is, you're looking at a controlled record here in Sri Lanka. Sadly, I have to admit that only in 2015 we have 10% uptake, so only 10% of our 23 million people have actually signed up for this scheme at present. And there are probably many reasons for that, and I think listening today when we start talking about accountability, privacy, confidentiality, those sorts of things, I think we've got a lot of work there to do to convince people and actually to satisfy ourselves as a nation that it is a safe place and that it will be used responsibly by the authorities and in ways that serve us as consumers and not necessarily for government needs. So I think there's a way to go there with that. I'm not going to say much more, except I thought you might be interested to know that people as young as 14 can actually register for a healthcare record. So you can actually, at the age of 14, get your own personally controlled health record, which means you don't need your parents' consent or anybody else to manage those files. So that's just interesting. I think here I saw yesterday it might be 16. Okay, so I'm just going to go on to nursing informatics. So that's a little bit about our context. So with the nursing informatics, you've already heard the definition. It's really science, information, knowledge and management information. And so I'm not really going to say too much more, but it is a combination of those three key things. And I think this slide's the important one. So it's about getting data and information, but what's important is that that data and information creates knowledge, and it's what we do with the knowledge that's important. So the wisdom that we get from this is what is key to us as nurses. So I think, and medical and health professionals in general. So I think we need to be asking ourselves, with all of the systems that we have in place, is like, and think from a nursing perspective in our discipline, what information would really help nurses help their patients? So we are patient advocates at the coalface, and so they're saying, we're there to look after the patients, but sometimes the patients don't necessarily, they trust us to get for them what they need at their time of need, because they don't always know what they, what's important and what's out there. So I think from nurses we can get wisdom from informatics and all of the tools available to us, but ask ourselves what's important, where are we going to spend our time and energy, and at the end of the day will it benefit our patients, because that's what we really want. We want those care outputs at the user end. I think just for talking now about training and the competency levels for our graduates, there aren't actually formalised competencies in informatics for nursing, and even though we have had informatics in healthcare in Australia for a good 3 decades, we are very slow in actually teaching that to our health professionals. So and having defined competencies about what are the skill sets and the knowledge that you need to work in informatics. And so this is something that we are now just really working towards. And at the University of Tasmania, we are actually about to embark on a new curriculum for our nurses. It's a 3-year degree program, And for the very first time, we are going to embed informatics as a core theme across the whole curriculum. We have other core themes such as clinical reasoning and communication, documentation, those sorts of things, safety. But now we're thinking about informatics in everything we do. And it fits, I think, because when you see how diverse informatics is, all the elements of it, the human, Dr. Tony talked earlier about the human element and the 10 core things that we need as humans to work in that space. Those 10 core things, including leadership, accountability, etc., they can be overlaid across everything that we teach, whether we're teaching wound care, medication management, those sorts of things. Those core human things can be embedded. So we believe that the informatics information is embedded across. I'm not going to really talk about the new technologies because I think the second speaker today, she talked a lot about those, and so we've seen a lot about what they can do, and you've seen some examples from the previous speaker. So the main thing is that we know that they're out there, but we need to be thinking about ensuring that our nurses know that they're out there and knowing how to apply them. And so if we use case studies and things like that in our curriculum, instead of perhaps teaching the old way of this is how you document, these are the legal ramifications for documentation, this is how you would frame it, we might talk about a paper document, but then we might also show in the classroom, or we might get an app and simulate how to do a discharge summary, as opposed to just talking about what a discharge summary is. We will embed as many of the informatic technologies and tools into the curriculum, whether we simulate it or not. That's what we're aiming to do. So I've probably jumped ahead a little bit because I think I might. Will you give me a couple of minute warning? I know that's okay. That in the past we might have traditionally, say for example on wound care, we might have given a lecture on wound care. We then might have done a tutorial, a practical tutorial where they actually practice on task trainers or mannequins how to do the wound care, including your hand washing and your product use, etc., wound assessment, and so on and so forth. And we might have some online materials to support that, so we do a blended learning approach. But what we're saying here with embedding informatics, we might still have the lecture and we still will have ordered learning, but it won't be just wound care. It would be wound care. We might talk about assessment techniques, then we might talk about informatics in so much that we have great databases on best practice in wound care products. So we would bring that website or that resource into that teaching, and so we'd actually be getting students to use that digital innovation and technology, and that's just a brief example. Medication management is another one. There are lots of safety and quality with medication management. There are self-checkout tests and a whole heap of resources. So when we teach medication, we that we're working, and every case study would be showing how that would be working and thinking about the aspects of that. And we haven't done it yet. I'll just keep moving. I've got that slide up twice. I'm just going to run through. I was going to say was that it is important then, getting to the wisdom, is that is that if we embed it, and it then makes more sense that people can apply it, because just trying to learn it as a discrete thing with how to use information technology, how to look at data, and how to do it in discrete bits doesn't work. We need it all embedded to get that wisdom and use it properly. And this is one of the examples that vital signs, but I've also given some other examples of the types of things there that we might be thinking about using into the future. I've come freely to that, but I hope that that's given you just a little bit of an insight into what we're thinking at the university and how we hope to move forward, and we acknowledge that it is long overdue. You know, like I said, 30 years of in clinical environments, and yet our students are coming out with very limited knowledge about what's out there and how to embed it in every day. And I think that it is, with the changing technologies so rapidly now, we need to get students to embrace it. And as our first speaker talked about those 10 human things, we need to talk about leadership in this space, and we need nurses to be aware that of how research and teaching and patient care into the future, and that's what we would hope to achieve. Okay, thank you.
Thank you. As I said, like, you must be having a lot of questions, so like we'll have the panel discussion at the end where you can forward your questions to all the three speakers. It is my